Good evening, everyone. My case for today is a multinodular goiter. My patient is a 27-year-old married lady who is a homemaker by occupation and is a resident of Ahmedabad. She presented primarily to the civil hospital Ahmedabad with the chief complaint of swelling in the front and side of the lower neck since last 5 years. The patient was relatively asymptomatic before 5 years, following which she developed complaint of swelling in the front and side of the lower neck. She first noticed the swelling about 5 years back. It was initially smaller in size and has then been gradually increasing to its current size. The swelling is not associated with any complaint of pain, difficulty in swallowing, breathing, or alteration of voice. There are no symptoms of hyperthyroidism like loss of weight despite good appetite, intolerance to heat, anxiety, tremors, diarrhea, etc. No symptoms of hypothyroidism such as lethargy, fatigue, constipation, intolerance to cold. There are no any other swelling in the neck or elsewhere in the body, or no history of any prior treatment for the swelling. Past history, there is no significant past medical or surgical history, and patient has no history of any radiation exposure. There is no history of similar swelling in the family or in the neighborhood, or no other significant family history. Patient is on a mixed Indian diet with normal appetite. She has normal sleep with regular bladder and bowel habits and no addiction. Her menstrual cycle is essentially regular, which is a 29 to 30 day cycle with 3 to 4 days of flow. Her obstetric history is she had 2 children, out of which the last delivery was 1.5 years back, and the previous delivery was around 4.5 years back. The first child died of unnatural causes. There is no history of any medication or any known allergy. Coming to examination, I have examined the patient under adequate light exposure and in different positions as required with proper consent and in the presence of female attendant. The patient is conscious, cooperative, and well-oriented to time, place, and person. She is average built and nourished with a BMI of 20.9. Temperature is normal by palpatory method. Pulse rate is 78 per minute with regular rhythm and normal force and volume in the right radial artery. The blood pressure is 116 by 76 millimeter of mercury in the right brachial artery in sitting position. And respiratory rate is 16 per minute. There is no pallor, icterus, clubbing, cyanosis, edema, or lymphadenopathy. Coming to examination for signs of toxicity, there are no fine tremors, no pretibial myxedema, no acropathy, the palms are not moist, and there are no eye signs present. On local examination, on inspection, it is an approximately 8 by 5 centimeter size butterfly-shaped swelling in the front and side of the lower neck. The swelling has well-defined margins. Superiorly,
Purvesh,
yes,
please go back. Keep the slide for a minute of photo here.
Yes, sir.
Okay. Now you can. So make it a habit. At least everybody should see. Then you can inspect, so they can correlate it back. Okay.
Yes, sir.
Continue.
On inspection, there is an 8 by 5 centimeter sized butterfly-shaped swelling, which is in front and the side of the lower neck. The swelling has well-defined margins, which is superiorly reaching up to the thyroid cartilage. Inferiorly, it is about 2 centimeters above the sternal notch, and laterally, it is up to the medial border of both the sternocleidomastoid. The surface appears to be nodular, and the swelling moves up with deglutition. The overlying skin is normal, and there are no other visible swellings in the neck. This is a video showing movement with deglutition. Coming to palpation, I have confirmed my inspectory findings on palpation. Swelling is normal temperature and is non-tender. It is an 8 by 5.5 centimeter size swelling in the front and side of the neck with well-defined margins. Inferiorly, 2 centimeters from the sternal notch, and laterally it is reaching up to the medial border of both the sternocleidomastoids. The swelling has the nodular surface with multiple nodules with variable, that is soft to firm consistency, and average size is 2 by 2 centimeters of the nodule. The swelling moves up with the deglutition, and lower border is palpable on deglutition. Swelling is not fixed to the overlying skin. There are no other palpable swellings in the neck. Cervical lymph nodes are not palpable. Trachea is felt in the midline, and bilateral carotid pulsations are felt normally. There is no thrill present. Percussion and auscultation are essentially normal. Systemic examination, respiratory system, bilateral breath sounds are present with no added sounds. On cardiovascular examination, S1, S2 is normal and no murmurs. CNS, the patient is conscious with GCS of 15/15. And on per abdominal examination, it is soft, non-tender with no organomegaly and normal bowel sounds. To summarize my case, it is a 27-year-old lady with complaint of swelling in front and the side of the lower neck, which has been gradually progressing in size with no features of compression, hypo or hyperthyroidism or malignancy. On examination, there is an 8 by 5.5 centimeter sized butterfly-shaped swelling in the region of thyroid, which has well-defined margins with palpable lower border and nodular surface with varying consistency, and the swelling moves with deglutition. My provisional diagnosis, it is a case of non-toxic multinodular goiter. Thank you.
Go to first slide. Let us start from beginning.
Yes, sir.
Okay. What is significance of residence?
Sir, in case of an goiter, endemic goiter is common along the banks of rivers, major in more specifically in the lower parts of the Himalaya, where the flow of the water is high enough to wash out the iodine, leading to iodine deficiency goiters.
What was my question, Purvesh?
Sir, significance of residence.
So where does the Himalaya comes in picture? What should be your answer?
Sir, to rule out endemicity.
What do you mean by endemic goiter?
Endemic goiter is one where it is present in a significant proportion of the population in a...
How much?
Sir, more than 10%.
At least 10% or more.
Yes, in a particular geographic region.
Now you answer sir's question.
So you should be saying, sir, the to rule out whether patient has come from endemic zone or not. Let the examiner ask, so what do you mean by endemic zone? Then the Kirit question, the answer will appear. And again, somebody may ask you, which are the common endemic zones? So you understand, you are answering 3 questions at a go. Then you can be in trouble, right? So
yes.
why it is common in these regions, foothills of Himalaya?
Sir, on the foothills of the Himalayas, the flow of the river is very fast. So the iodine is washed away from the soil. And because of that, there is iodine deficiency goiter.
That is the reason. Any other reason? In other words, why it does not occur over the mountain and in foothills of?
The soil is not rich in iodine.
Which soil? That is the important. That's the point. In mountain region itself, the soil is okay with iodine, but when it reaches up to foothills, it is being washed off by the dust. That's why it is common in foothills. That is Himalaya, which is common nearby.
Sir, in the south of
our state, in our state, or in other words, in the west zone, which are the area where you are likely to find the endemic goiter? That is usually in Gujarat, yes.
Sorry, sir, I'm not sure.
So it is usually near the Surat, between Surat and Nandarbar. That is a border of Gujarat and Maharashtra. That is the area where you get lot of patients having endemic goiter. So why does the endemic goiter develop?
Sir, due to deficiency of iodine, there is a deficiency of thyroid hormone. The hormone levels are deficient. Because of that, there is a...
Sorry. Hormone levels are never deficient. Endemic goiter are euthyroid patients. So don't use word deficient. Then all of them are hypothyroid?
No, sir.
You will never find hypothyroid among, rarely endemic goiter. So don't say deficiency of iodine, why there is a development of endemic goiter.
Sir, it leads to a stimulation of the thyroid stimulating hormone to be secreted from the anterior pituitary.
So what does secrete TLA, what does stimulate TSH?
Sir,
What happens?
Why low iodine leads to increased THL secretion?
That is an important point.
Sir, due to low iodine, the synthesis of thyroid hormone is less. The synthesis of T3, T4 is less in the gland. So, as a feedback, there will be increased stimulation of TSH.
Okay.
So what happens? But why there is a enlargement of gland?
Sir, with the increased TSH stimulation, initially there is a diffuse hyperplasia of the gland, which leads to the first stage, that is the diffuse hyperplastic goiter.
What do you call long-term endemic goiter? What do you call it? What is name for a long plus? Usually endemic goiters are known as other name for that. They are known as a colloid goiter.
Colloid goiter.
So what is colloid?
So after the initial diffuse hyperstimulation, there will be pulsatile stimulation of the TSH, which will lead to some of the follicles will be hyperactive, while some will stop. Will be
You are jumping the gun. You are talking about nodule. I am not
MultiNodular.
asking about nodule.
Sir is asking only goiter. Why there is a goiter? You first answer that, then there will be nodularity.
First, there should be goiter.
Yes, sir.
So what happens? I have given you a hint in the form of colloid. Do you understand? If there
Yes,
is
sir.
a TSH stimulation occur,
Yes,
right?
sir. Yes,
So
sir.
what does it cause?
Sir, due to TSH stimulation, there will be hyperplasia of the follicles with
No,
accumulation.
that is fine. If there is a hyperplasia, why the gland enlarge?
So there will be accumulation of the colloid in the lobules.
So that is what the case. Why there is why colloid accumulate?
What is colloid?
Colloid is the material found in the center of the follicles containing the thyroglobulin where the synthesis of the thyroid hormone takes place.
Very good. So why there is an increased colloid?
So TSH will have a stimulatory
Forget
effect.
about TSH. Forget about TSH. The point is that you should correlate with the iodine deficiency. The hyperplasia, and that is common in Graves' disease or isolated nodule. Here, hyperactivity is not there. But because the iodine deficiency, it creates a vicious cycle. How does it do? There is an initial iodine deficiency. The full form, mature form of T3, T4 is not there because required iodine is not there. So MIT-DIT is synthesized in more form, which collects inside the acini, forming what is known as a colloid, right? Okay. But it causes relative deficiency of thyroid hormone. So TSH is stimulated by negative feedback mechanism. So it will try to stimulate the thyroid. So again, there will be more synthesis. But as the iodine is deficient, there will not be actually mature thyroxine production. So incomplete produced thyroid will be collected, inside the nodule, giving rise to large colloid collection inside acini. And acini become flattened cells. The normal acini is a cuboid cell. But when it becomes a Graves' disease, it will become a columnar cell with minimum colloid. So whatever is synthesized is secreted. Whereas here, over the period of time, it will become flattened. So the thyroid enlarge because of the large colloid collection. So it is not a hypertrophy, understand this one, yes, or hyperplasia. That is initial, but actually long-term endemic goiter gives rise to colloid nodule. Okay. Sorry, colloid goiter. So what is difference between hyperplastic goiter and colloid goiter? Welcome, Dilip bhai. Please.
Yes, very good evening. Yes, I have just joined. Right.
Okay.
Sir, in hyperplastic goiter, there will be hyperplasia of the follicles, of the follicular cells.
Yes.
And in colloid goiter, there is
that is at the pathophysiology, right?
Yes,
what
sir.
Clinically, how will you differentiate hyperplastic goiter and colloid goiter? One is hyperplastic goiters are usually sporadic, and they are more common with sporadic iodine deficiency, pregnancy, puberty, physiology. so on. So what is the clinical difference between colloid goiter and hyperplastic goiter? We are talking of diffuse goiter.
Sir, hyperplastic goiter would present at an earlier age. Usually in the adolescence or at the time of puberty, and in case of females at the time of stress like pregnancy.
No, that is a physiological goiter. I was just giving example. Iodine deficiency can occur anytime. What is sporadic goiter?
What are the different causes of goiter except endemic goiter?
It can be due to any drugs such as iodine or amiodarone. It can be due to neoplasms such as adenomas or carcinomas. It can be due to thyroiditis, inflammation like acute, subacute thyroiditis or autoimmune thyroiditis. And,
but what do you mean by sporadic goiter? Yes. So the goiter occurring isolated incidents in any area. The cause may be iodine deficiency, may be dysharmonogenesis or any other, right? So the basic difference between hyperplastic goiter and hyperplastic goiter occurs usually in a sporadic way, whereas colloid goiter are common in endemic area. The hyperplastic goiters does not become very large. They do not attain very large, and they tend to convert to multinodular goiter more. Colloid goiters usually in endemic zone becomes very large without converting into nodule. Why?
Okay, do you have any enzyme deficiency which can lead to the occurrence of the sporadic goiter?
Sir, in case of deficiency of thyroid peroxidase enzyme, which
Yes,
is
very good.
seen in dysharmogenesis.
Okay, can it be associated with some syndrome in which one of the component is a deafness also associated with that?
Yes, sir. It is seen in Pendred syndrome, which is an autosomal recessive disorder.
Okay, fine. Go ahead. Right.
Okay. So why the sporadic goiter or a hyperplastic goiter likely to convert into multinodular and endemic goiter are not likely?
Sir, in
How the nodularity develops that you were just speaking before.
Just telling me, that's why I have asked you.
What is the factor responsible for occurrence of the multiple nodules in the thyroid gland? If you know that etiology, then you will be able to answer it well.
yes, sir. In case of nodular goiter, with time there will be pulsatile. The continuous stimulation is changed to pulsatile stimulation of the TSH, following which some of the nodules will remain hyperfunctioning while some will become inactive, and this occurs due to multiple clones of the cells.
Okay, so the better word is a fluctuating level of the TSH level, right? Fluctuating level of the TSH level. So that will be some hyperplastic formation, and whenever there is excessive growth onto the one particular follicles, there will be development of hemorrhage into that, and that hemorrhage lead to the occurrence of the inactivity of that particular nodule. And whenever that inactive nodule multiple gets collected, it form a much more prominent nodule in short. So exact etiology for occurrence of the nodule is a high fluctuating level of the TSH level.
As well as differential growth of the follicular cells, differential growth potential of the follicular cells.
Yes, sir.
That is your answer. Why endemic goiter does not become usually into multinodular goiter and they go on increasing. Can you answer it now?
In case of endemic goiter, because of the inciting factor such as iodine deficiency, will continue to have continuous stimulation of the TSH.
The point is that there is no fluctuation.
Fluctuation won't be present in that. So
it is a persistent iodine deficiency over the period of years, leading to more and more colloids, because the TSH will not have the reason is TSH fluctuation. Why there is a TSH fluctuation? The production of T3, T4 variable depends upon the time factors, and that leads to nodule formation. Here in an endemic area, it is a persistent same iodine deficiency. So usually colloid goiter is that one. Second, once that there is an excessive collection of colloid goiter, the whole acini relatively becomes inactive. So then there is a fluctuation, does not affect, and it will remain in status of limbo. That gives rise to usually nodules do not develop. Right? Because your case is multinodular goiter, this is going to be asked.
yes,
One part, as sir has said, why nodule develops, and second, why nodule do not develop.
yes, sir.
Right?
Okay.
Okay. Next. Okay. Next. Sir, if you want to ask, you can read and.
Right.
What are the boundaries? How you can say upper neck and lower neck?
Sir, actually, that was what the patient told. The patient came and told it was in the lower half of the neck.
So how it started? It started as a diffuse or a single nodule on the lower neck on right side, left side, or in the center of the neck?
Sir, the patient didn't clearly remember, but it was like a diffuse swelling, and she told that she noticed it in around the midline.
Around the midline.
Yes,
and
sir.
then it become butterfly.
Then it was gradually increased, sir.
So when she noticed first and at the present swelling, what is the change in the size?
Sir, initially it was around lemon sized, and currently it is around the size of a tennis ball, sir.
A lemon and tennis ball, and initially you said it's a butterfly shaped swelling.
So this is what, sir.
So I'm just asking shape and size both.
Sir, the patient couldn't exactly tell the size in the dimension. So what she mentioned in her layman's language, it was size of a small lemon, which is growing to the size of a ball now.
Okay, other way is to use, you can say whether it is double in size or it has increased 3 times in size, rather than saying about lemon or tennis ball or like that. That is one of the way by which you can explain. It has double, triple, like that.
Okay, sir.
What change in the size of the thyroid should occur to become palpable or become goiter, palpable goiter or visible goiter? At least double the size.
Purvesh,
Yes,
this
sir.
also you need to practice. Sir, I don't know. So
Yes,
you can
sir.
go forward. Here
Yes,
we have unlimited time, but when you will present in RRC, it will be only 40 minutes at the most.
Yes,
so
sir.
do not waste the time. Right? If you know it, it's fine. If you don't know it, it's okay. So the
Okay, sir.
examiner will answer. Kirit Bhai, but before that you should have said, sorry sir, I don't know. That's okay.
Yes.
I don't have idea, or whatever you want to say. So at
Yes.
least it will be conveyed. You are hearing what the examiner is saying, but you are unable to answer. Sometimes what happens on web platform, when we are present physically, we will be able to see your facial expression. We can repeat it. Here we are not sure whether the connection is there or not. So
Yes,
the communication channel should be completely open. This time, that's why we have taken this case. So you should understand that
Yes, sir.
it is a communication should be there. So at least you should acknowledge that what the question was asked, whether you are able to answer or not. Or sometimes it will happen that you may not hear it properly, particularly 4 or 5 examiners are there. In that case, without hesitation, sorry sir, I could not follow you. Can you repeat it? So make these habits which are important when you are presenting in web platform, right?
Yes, sir.
Okay.
Yes, sir.
Otherwise, the question will come. Can you hear me? Can you hear me?
Like that. Do you understand?
Yes, sir.
These are the small points. Yes. Kirit, you are saying something?
Please, sir. Sorry, I interrupt karya tha humne.
Okay. No, okay.
I just wanted to say that instead you speaking lower neck, rather you can say neck only.
Okay, sir.
Fine, no issue. Right?
Yes, sir.
Next.
I would like to interrupt here. Many examiners do expect that you should say upper neck or lower neck, and many examiners do expect you may not say. So you have to judge examiner's mood. There will be another examiner like me who may try to protect you, and there are some examiners who will not interrupt, but it's okay, Kirit, I think. Some examiners at national level also expect you should say lower part so that it becomes more predictable to say that it is thyroid.
So
Just
then the question might come that what is upper neck and what is lower neck? How you differentiate that?
So also there is a third point. I did not want to raise this question. Some believe that you should say thyroid area.
Yes, just like parotid.
Like parotid. So that is also there, but it's all right. You should not well. So what is the trick? Go with the examiner. Yes, sir. Sorry, sir. Those are
In
the
case
points.
of lower neck, you can say that it was more towards manubrium, upper towards chin, or you can say like that. But it's fine. It is. You can say that front of the neck. That will be enough.
Okay, sir.
What are the causes of pain in nodular goiters?
Pain will appear in case of an intranodular hemorrhage, or in case of thyroiditis, or if in case of malignancy.
In malignancy, why there should be pain?
Sir,
In malignancy, there will
sir,
be...
in case of anaplastic carcinoma, there will be pain, sir.
Okay, and why there is sudden hemorrhages in nodules?
So, I don't know, sir.
Okay. So there is the low vascularity might give rise to necrosis of that areas. Okay. Next slide.
Okay, wait. Why you ask the history of difficulty in swallowing, breathing, alteration of the voice, and all this question?
Sir, it was to rule out any compressive symptom due to the goiter.
How this multinodular goiter is going to compress the respiratory system rather than trachea, so that it leads to the difficulty in breathing?
There will be, in case of large goiter, there will be indentation over the trachea, which will lead to dyspnea.
Okay, you said large goiter, right? Now,
yes, sir.
It is very well covered by the tracheal ring. You don't expect any large goiter to cause compression of the trachea. It has got very good ring over the front side.
Yes, sir. Sir,
maintain the airway.
Sir, it was also to rule out any infiltration in case of malignancy.
Where infiltration?
Sir, in case of malignancy, there might be infiltration of the trachea, which would lead to...
That's why I'm telling you, the trachea has got a very good ring on the front, right, left side. Only on the back side, there is no ring.
And, sir, there might be infiltration
Difficulty
of...
in breathing.
Sir, there would be infiltration of the vocal cords.
Listen. Going thyroid malignancy up to the vocal cords causing, that is not a digestible thing. Tell me certain valid reason for that.
Yes, sir. In case of malignancy, there might be infiltration of the recurrent laryngeal nerve.
Oh, that's good. Right.
Which may lead to the vocal cord paralysis and then difficulty in breathing, sir.
Okay. And what about you said huge size, no? It is not important the huge size. It is the how long the swelling is there. That is important. It's a important rather than a size. It may be average or big size, but it is a duration since when the goiter is there. That is important. And why it leads to difficulty in breathing if the long standing huge goiter?
Sir, there will be weakening of the tracheal rings due to long standing goiter. With the washout of the calcium.
Why there will be weakness of the tracheal ring?
So there will be washout of the calcium leading to the softening of the calcium, softening of the tracheal ring, sir.
Right. So it
Which
will
you say there can be or there may be. There will be is a definite statement that it always happens, right?
There can be, sir.
Yes.
okay.
The problem, why this problem has arisen, you understand, Purvesh, why this problem has arisen in your case?
Yes,
Why?
sir.
You have given more significance to this rather than patient is hypo, hyper or not. Do you understand?
Yes,
Make
sir.
it a point in all thyroid swelling, difficulty in swallowing, breathing, and alteration of voice comes last. Why? Because they are
Yes.
rare.
Yes, sir.
Do you understand? They are
Yes, sir.
extremely rare to find this. It is more important to establish whether the patient is euthyroid, hypothyroid, or hyperthyroid. That is more important. Yes,
Okay,
that is there. But why you have taken swallowing first?
there was no actually particular reason. Am I audible, sir?
Yes, yes. You want to rule out that this swelling is not a malignant.
So-
That is why do you include it in a higher level, right? But why not to keep it late? As such, your case is such that it is less likely of malignancy
Yes.
from
Yes,
symptoms.
sir.
See,
And all. So at the end, you
don't
know,
try-
and why not to bring it higher rather than bringing it lower rather than bringing it at a higher place, right?
Yes, sir. Okay, sir.
Now, you ask about any other swelling in the neck or elsewhere in the body. Why do you ask this question?
Sir, in the neck to rule out any lymph node involvement.
Okay, so you do expect some enlargement of the lymph node. That's why you say about the neck. Why you
Yes.
say elsewhere in the body?
Sir, the swelling.
Where do you expect? Elsewhere means where?
Sir, to rule out generalized lymphadenopathy, sir.
Oh, that.
That is, you are in
relation to
trouble
the
now.
thyroid. Now you make specific in relation to the thyroid. We had already discussed this matter earlier in your thyroid case and everything in this PG master class also. That's why I'm asking you.
Sorry, sir, I'm not sure, sir.
Okay, why you examine abdomen in a case of thyroid swelling?
Sir, it is to rule out lymphoma, hepatosplenomegaly, sir.
Okay, one is lymphoma. You may get hepatomegaly, splenomegaly, right?
Yes,
Okay.
sir.
The reason, any association with the thyroid swelling with the lump in abdomen? Any other association? Any other condition which can produce that?
There, in case of medullary carcinoma,
Why?
which is associated with MEN syndrome, sir.
Yes, MEN2, right?
MEN2,
You
there
may
will
be
be-
expecting an associated lump in abdomen, but usually it is the pheochromocytoma you are suspecting. But pheochromocytoma doesn't produce such a huge lump.
Yes,
If
sir.
small lump of 5 by 5 centimeter size, it will be very much symptomatic, and the patient will not notice lump. Wait, he will be symptomatic before lump. But any other reason why thyroid swelling is associated with lump in abdomen? What is Hashimoto's disease?
Sir, it is an autoimmune disease where is chronic lymphocytic
So do
thyroid.
you expect enlargement of the spleen also in some of the cases of Hashimoto's disease?
Yes, sir.
So in this way, you should have quick answer that this is the reason why you are asking any question that you are writing in ODP. Correct? Now, do you
Yes, sir.
expect any swelling in the scalp which is pulsatile in thyroid swelling?
Sir, in case of follicular carcinoma, the metastasis to the skull would be pulsatile.
Yes. Why it will be pulsatile?
Sir, because it is highly vascular.
What is the reason for the presence of pulsation in the scalp swelling of malignancy which is secondary to the from the thyroid? Why it will be pulsatile? It is because of the vascularity or because of some other reason?
Due to vascularity.
It is
No,
osteoclastic or
listen. It is the pulsations which you see in the swelling is because of a routine brain pulsation. But it is the osteolytic lesion over the whole scalp that leads to simple loss of the all hardness and bony portions of that particular swelling. And that's why what pulsations you observe is actually the pulsation of the brain.
Okay, sir.
Right? Now, this matter was also discussed very well in RRC just 2-3 days back only. That's why I am asking you. If you are attending all these things, you just keep in mind all the answers which was discussed there. And second thing, in RRC, whenever you are facing such a case of thyroid, you go through all the cases that were previously discussed about the thyroid swelling.
Yes, sir.
Of the teachers, or specifically Dr. John Abraham, Santosh Abraham rather, that they will not take the matter which is already discussed in the past.
Yes, sir.
So it is, they are presuming that you are aware of that thing.
Okay, sir.
So always try to dig whatever the other things which are not covered in the previous cases of the thyroid or anything.
Yes, sir.
With it, right?
You have said no other swelling in the neck. I would like to go back there.
Yes.
Why?
Yes. Sir, to rule out lymph node metastasis.
Okay, metastasis or to lymph node. What do you call it?
Sir, in case of papillary thyroid carcinoma, involvement of the lateral lymph node will lead to lateral aberrant thyroid.
Okay. Right. So do you expect in your case?
Sir, no. In this case, it will be unlikely, sir.
Okay. But I would rather suggest you say no other visible, no other. We are in history, no history of other swelling. It's okay, sir. Let it go. What do you mean by any prior treatment for swelling?
Sir, it was to know whether the patient was presenting for the first time or had she been taking any treatment for the swelling.
I think you have taken a drug history also. So how will it differ from this? I think you have taken drug history also.
Yes, sir.
So you are going to say that what drug patient might have taken?
So the patient may be taking any for goiter thyroid drugs or thyroxine.
Thyroxine. So goiter. What is the principle of prescribing?
Sorry, sir, I couldn't hear you.
Why thyroxine is many times prescribed?
Sir, am I audible?
I think I have lost my connection. Am I audible now?
Yes, sir. Yes, sir.
Okay. I think the connection is the problem. What I was asking you is why thyroxine is prescribed many times in a goiter.
Sir, it is prescribed as a suppressive therapy, sir.
Okay.
With the by administering thyroxine, that will lead to the decrease in the TSH, which will lead to the decreased stimulation and the enlargement of the gland, sir.
Okay, if the patient is having iodine deficiency goiter, patient has come from endemic area, and
Yes.
patient is having an endemic goiter which is not very large.
Yes, sir.
So would you prescribe thyroxine or will you prescribe iodine?
Sir, in that case, I'd prescribe iodine, sir. Ask the
What
patient to have iodine rich diet.
will happen
sir.
if you prescribe iodine?
Sir, for in case in form of sir diet in the dietary.
No, sir is asking what will happen if you give iodine.
Apurva, please continue. I think mic on
Yes,
my
sir.
on, so I may not be audible many times. So continue discussion if I am not audible.
Yeah,
or-
sir.
Okay.
Yeah, fine. So what sir is asking is what will happen if you are giving iodine to the patient?
Sir, iodine will lead. It will lead to further.
Sir has a very specific question. Patient has come with a very small goiter when the patient, so from an endemic area. If you will give iodine, the patient will have iodine, but the hyperfunctioning will continue and it will increase the size of the gland.
Yes,
Whereas
sir.
to decrease you have to reduce the TSH.
Yes, sir.
And you reduce the TSH by giving thyroxine.
Thyroxine, sir.
Right. So you start altroxin, and then once you start altroxin, after that you give iodine so that it is balanced.
Yes, sir.
Right. So
Okay,
thyroid will help in reducing the TSH level so that hyperfunctioning and increase in size of thyroid does not occur. Okay.
Okay, sir.
Okay.
Colloid goiter will respond to the iodine therapy, or it is hyperplastic goiter that will only respond?
Sir, hyperplastic goiter would respond.
What about the colloid goiter? If you give iodine in colloid goiter, then
Sir, it will the gland will accumulate the iodine, and there will be
So basically, a colloid will continue accumulating.
yes, sir.
Right.
okay, go ahead with the next slide.
Yeah. Andhar Sahib, anything from your side?
You are unmute on Hitesh.
Yes, yes, I'm here only. Carry on.
Yes.
Okay, carry on.
I'm here only.
Okay.
This is the question which will create a lot of problem, I believe. No history of any radiation exposure. This has been discussed many times. Nobody comes to actual conclusion. If my choice is that I will not discuss this, means don't mention it.
Okay, sir.
Why you need to mention about radiation exposure without any significant history?
Sir, it was only for the sake of completion of the.
No. There is nothing like
point-
sake of completion. So what do you want to complete? Yes, sir.
No, sir. Louis, the point is that previously the radiations were high when we are taking X-ray chest or mammography or something. Nowadays, the irradiation, we don't irradiate the patient to that level that it will develop malignancy.
Yes, sir.
I think sir is right. Sahib ji kaise baat sachi hai ki you should rather omit
You
it.
should not, because it can be a problem. What are the thyroid area is exposed to radiation? There is a history of being given radiation in case of tonsillitis also. That was also in the past. Nowadays, a patient having some associated malignant condition is being radiated, or a patient is coming from the area where the radiation level is high, then the discussion can go up to Chernobyl or what not.
So if you are prepared very well,
So it is better
then
like that.
better to bring it, otherwise forget it.
Okay, sir.
Why you ask for past surgical history?
That's why, what do you want to say about that radiation?
Yes, yes, sir. Radiation, it is certain errors are better to be omitted rather than committed.
If somebody asks, you can always, sir, I have asked, but it is not significant, so I have not taken, no problem.
Yes.
Okay, sir.
Kirit was asking something. Kirit?
Kirit bhai.
Sir, what is the importance of asking past surgical history? Why you ask that?
Sir, to know if the patient had any previous surgery
Any
for the in the neck region, sir.
What is the significance?
It could be recurrent swelling. If there was if the patient had been operated and then the swelling had reappeared.
So whether it was recurrent thyroid swelling or not, that you can always ask.
Yes, sir.
So what surgery might have been done at that time?
Sir, a patient may have undergone lobectomy, sir.
Or subtotal thyroidectomy?
Yes, sir. Yeah, anything less than total thyroidectomy, sir.
Okay, next. Hello?
So why you said no history of similar swelling in the family?
Sir, in case of if it was an endemic goiter, number of the members of the family and even in the neighbor, similar complaint would be present. So it was to rule out any endemic goiter.
Okay, any other reason?
Sir, and to rule out any familial association, such as in dyshomogenesis.
Okay. Any other thing?
And in case of malignancy, sir.
Which malignancies are likely to occur in the family in relation to the thyroid swelling?
Sir, medullary thyroid carcinoma are familial.
Okay, that is one. Any other?
Uh,
Even the papillary carcinomas are also known to occur in the family. You should keep that thing in mind also. Both the things will come. Okay. Go to the next slide.
Which are the goitrogens in the food?
Sir, brassica, the food from brassica family like cabbage, kale.
So what they do?
Sir, they will contain thiocyanate, which will inhibit the iodine trapping, iodine uptake, and that will lead to the formation of the goiter, sir.
Why you ask for whether mixed diet or not? What is the importance of that?
Sir, if the patient is taking a diet rich in food like eggs and saltwater and fish, chance of iodine deficiency is comparatively less.
So which are the iodine-rich diet?
So food like iodized salt, eggs,
Diets. Okay.
fish, dairy products.
Okay. What is the daily requirement of iodine?
It is around 100 to 110 micrograms per day.
Dr. Sahib, anything, or we'll skip to the next slide?
Next slide.
Okay. I think this slide also you can omit.
Yes.
Okay.
Okay, sir.
Next slide.
So what are the different positions for thyroid examination you have noted, and when do you need those positions?
Yes, sir. Sir, for any examination of the thyroid, the inspection should be done from the front, and palpation should be done from the back as well as from the front. Other than that, there are various maneuvers to palpate the gland. In case of short neck person, there is the Pizillo's method, which is used. And
What do they do in Pizillo's?
Sir, in the Pizillo's method, the patient is asked to clasp the hand behind the occiput and against resistance from the hand,
yes.
extend the neck, sir.
Yes, very good. Okay.
It is particularly useful in patient with short neck and thick neck, sir.
Short neck. Yes, fine.
Sir, other than that, the Lahaye's method of palpation is used to examine the particular lobe more carefully.
Okay.
What is Crayal's method of examination?
So, Crayal's method is used for taking the pulse rate, the sleeping pulse rate.
No, that is not. It is a part of a neck examination only.
Sir, yes, sir.
You stand in the front side of the patient.
Yes, sir.
And ask the patient to swallow. Keep your pulp of the thumb or the aspected place where there is swelling. And if there is swelling, when you ask the patient to swallow something, you will find a small tug at that particular thumb side whenever the patient swallows.
Yes, sir.
Okay, why you examine the patient keeping the hand by the side of the head, raise hands?
Sorry, sir.
Why you examine the patient? One of the method is to examine the patient, asking the patient to raise the hand keeping by the side of the neck.
Sir, It is known as Pemberton's method. It is
Yes.
to rule out the substernal, the retrosternal goiter extension. Because in that case, there will be pressure on the veins, which will lead to the flushing of the face. The patient is asked to raise the hand by the side of the head by the ears, and that will lead to the flushing of the face.
Okay, what is the classical method of examination of the neck? Classical method of examination of the neck.
The Lahaye's method, sir.
No, that is not a Lahaye's method. That is applicable in any neck swelling palpation. Classical method. Where do you stand? Where will you keep your thumb? Where will you keep your forefinger? What will you ask the patient to do? What will you ask the patient to do about the shoulder? What will you ask the patient to keep a chin where? All these points should be considered when you are asked that question of classical method of examination of the neck.
Yes, sir. Sir, we'll be standing behind the patient.
Yes,
and the
very good.
patient is asked to extend the neck with the thumb on the neck.
Listen,
between the neck.
one thing you listen. When you ask the patient to extend the neck, hold the segment of trachea and larynx and everything will become fixed.
Yes, sir.
When you want to assess the mobility and that, you always ask the patient to keep that flex, right? Then only you will be able to judge the mobility in relation to that segment and its own swelling mobility and that. Okay?
Yes, sir. So the thumbs will be placed on the nape of the neck, and with the forefingers placed on the front of the neck. And we will ask the patient to swallow and feel for the movement with the fingertips, sir.
Oh, that is one of the part of it. But otherwise also you can examine the other parts of the, say if you want to examine one lobe prominent, you can shift the lobe to the opposite side and palpate the surface of the lobe. The only way to palpate the posterior part of the thyroid gland is to keep the swelling on one side and palpate the prominent side or the back side of the thyroid. That is the only way. Otherwise, on front side, you can't judge about the just lateral and posterolateral surface of the thyroid gland.
Yes,
Right?
sir. Yes, sir.
Remember that thing.
Yes, sir.
Okay, you can go on for that other general examination slide. Temperature, pulse, blood pressure, respiration. No palloritis, clubbing sinus.
Dilip, I would like to, because my connection was poor, I was not. I would like to ask you, go back one slide, please.
Yes.
Okay, not general. Go one back. But one forward. Forward, please. Okay. So you say when you examine the thyroid, you will stand in front or in back. You said back, right?
Yes, sir.
Why?
Hello.
For inspection, we need to inspect the gland from the front. Am I audible, sir?
હા તો આવી જાઓ. તમે આવી નથી ગયા ને? શું નથી ને? ક્યાંથી આવવાના તમે? હા એટલે કારણ કે ગઈકાલે શું એક સર્જરીમાં ફસાઈ ગયો હતો એટલે મારે 7:30-8 વાગી ગયા હતા એટલે.
Sorry, I did not hear you. Sorry, please repeat.
Yes, sir. For inspection, we need to stand in the. We need to carry out the inspection from the front, sir.
Okay.
And for palpation, we need to stand behind the patient.
Why? Why? Inspection, I can understand. Obviously, you'll have to stand in the front, right? Why from behind? How does it help you and patient both? So the difference is when you inspect, you keep the neck in slightly extended position. So you can see the thyroid swelling and see the movement with deglutition. But from back, you make the the neck little bit flex. Why?
Sir, it is to relax the sternocleidomastoid muscle, sir.
You have said your swelling is up to medial border of sternocleidomastoid.
Yes.
So according to you, there we were going to come there. That is a wrong concept you have got. It is usually extend up to lateral border of sternocleidomastoid behind the sternocleidomastoid.
And sir, with the extension, the whole complex, the thyroid and the laryngeal complex would be fixed, sir. So we won't be able to check for the mobility.
Thyroid. What happens when the neck extends? Which is an important structure which keep everything in neck. A very important structure.
Sir, it is the deep cervical fascia, sir.
Which part? There are 3 deep cervical fascia.
So the pretracheal fascia.
No. It's an investing
layer, the superficial layer of the deep fascia.
Not superficial layer, it's the outer layer. Superficial is the wrong word. It's the outer layer. So why it is important?
Sir, on extension, it will be there will be stretching.
Remember, the thyroid is between prevertebral fascia and investing layer, and it is covered by pretracheal fascia. The pretracheal fascia is not fixed with anything; it's a loose tissue comparatively, whereas the investing layer is a tough and it is attached everywhere. Superiorly, it is attached with the mandible and goes up to back. Similarly, lower part it attached up to clavicle and sternum. So it is the tight fixed area. So if you extend it, it will prevent your fine palpation of.
Yes, sir. Sir, I cannot hear you.
Neck should be in a flex position. One. My problem is that. Now, am I audible?
Yes, sir.
So when you palpate from behind and in flex position, patient is also comfortable. Yes, whereas if you try to palpate from front, it will be very inconvenient. That's why the Pisello, Kreil and Lahez methods are not a routine method of examination. As Sir had said, always describe classic method, and if it is a nodule, then you can use a Lahez or Kreil, but never in a diffuse goiter mention about Lahez or a Kreil's method.
Okay, sir.
Do you understand?
Yes,
and
sir.
Pisello is meant for a special cases. Do you understand? Where you examine from front, but
Yes,
normal classical is always examined from back. Okay,
yes,
please continue.
Have you taken the sleeping pulse rate?
Yeah.
No, sir.
Why?
The sleeping pulse rate is mainly to rule out thyrotoxicosis, and in this case, the patient didn't have other features, so sir, I didn't go for the sleeping pulse rate.
What is sleeping pulse rate?
Sir, the sleeping, there is a Kreil's grading for the sleeping pulse rate, which is used in case of thyrotoxicosis. In grade 1, the rate is from 90 to 100. In grade 2,
my question is what is sleeping rate?
Yeah, you please listen to what the examiner is asking. Kirit Bhai is asking, what do you mean by the word sleeping pulse rate?
Sir, sleeping pulse rate is the one. It is taken when the patient is in sleep, when the patient is asleep, and
How many hours after sleep?
So I will give you a hint. There is a something like casual pulse, resting pulse, and sleeping pulse.
So what is the difference?
What are the types of sleep you know?
sir, REM and NREM sleeps.
So what is the difference in that? Will you take pulse in REM or NREM sleep?
No, Kirit Bhai, now it is going very deep. Answer him, please. Okay. No, it's fine, but it's important. We are taking the questions which are unlikely. Routine, all you know.
Yes.
Okay. Kirit Bhai, please answer him.
Yes, sir. It is in non-REM sleep when the patient is in the deep sleep,
Yes,
right?
sir. Yes,
At
sir.
that time, the pulse rate should be taken.
Exactly. So it is a resting pulse most of the time. So you should understand what do you mean by resting pulse.
Purvesh,
Yes, sir.
answer.
Sir, it is the resting pulse is the one which is taken when the patient is not in an agitated state.
The point is that you should always take a pulse of any thyroid case, whether it is toxic, non-toxic, resting pulse is mandatory. Keep this thing in mind.
Yes.
Do you necessary? Unless you take pulse and patient has a tachycardia, how will you know the patient is thyrotoxic or not? One important differentiating point. So resting pulse is at least a 5 minute of inactivity of a patient. After that, you take a pulse, and pulse should be taken for whole minute.
Yes, sir.
Sleeping pulse. Why do we take sleeping pulse?
Sir, in case of thyroid toxicosis, sir, it is to differentiate whether the irregular pulse or the tachycardia, whether it is due to thyroid toxicosis or due to anxiety, sir.
Do not use word arrhythmia. Arrhythmia will not come in picture. Do you understand?
Yes, sir.
So think of only tachycardia.
Yes, sir.
So how will it differentiate?
Sir, in case of anxiety, the pulse will be normal, sir. There won't be any tachycardia. While in case of actual case of thyroid toxicosis, there will be tachycardia present even in case of a sleeping pulse.
Why it is mandatory to differentiate anxiety?
So that is because it will guide it is going to guide the further treatment, sir.
No. How will it guide the further treatment? The point answer is that many a time anxiety mimic like early thyrotoxicosis. Do you understand?
Yes, sir.
Anxious patient will exactly look like a early thyrotoxicosis, and they will be tachycardia. So to rule out the tachycardia of anxiety, you take a sleeping pulse.
Okay, sir.
Right?
Yes, sir.
Which becomes more and more important when the patient is on medication of antithyroid drug.
Yes, sir.
Because what will happen if you're not taking a sleeping pulse or resting pulse in thyrotoxic patient after starting treatment, you may go on increasing the dose.
Yes, sir.
So anti-anxiety, anxiolytic also given, propranolol also given, but still the pulse should be taken at least a resting or sleeping. Similarly, there will be a discussion of hyperdynamic circulation. I will not go in detail. Do you want to ask anything about that, Dilip bhai? I think
Yes, why he should know what is water hammer pulse, how to place it, and what are the different causes of that particular reason.
Right.
So at
And
least
why?
you should know that.
Yes, very good.
Your
Yes.
case is a non-toxic multinodular goiter, so we may not ask that question.
Ask it, but you should keep in mind.
Only asked
Yes.
in the exam. Right?
Yes, sir. Sir,
Okay,
water.
I will pass. We will pass it. No problem. Next.
So go to the next slide.
And one more point again, if it is toxic goiter, clubbing you should know.
Yes,
Because
sir.
that is the point. Okay. This is the one more point. Okay, we'll not go in detail of that because it's not a multi-toxic.
Okay, I would like to ask one question. In
Please.
ICU, you must have considered that all the toxic primary hyperthyroid toxicosis and all the eye signs related to that, right?
Yes, sir.
Now,
Yes,
my
sir.
question is whether the patient can develop dropping of the upper eyelid in thyroid case, thyroid swelling.
Sir, can you repeat the question, please?
Dropping of the upper eyelid in thyroid swelling, can it happen?
Sir, it can.
Related to toxicosis, that's why I'm asking you.
Yes, sir. It can occur if there is involvement of the cervical sympathetic chain leading to Horner syndrome, sir.
Yes, so if it is a sympathetic trunk involvement, better word is a sympathetic trunk involvement, right? It
Yes,
may
sir.
of the huge swelling, retrosternal compressing over that. And second is the malignancy infiltrating into the sympathetic trunk. So this can cause a dropping of the upper eyelid with all the typical signs of Horner syndrome.
Yes, sir.
Who mentioned in the book and in some clinical books also it is mentioned and you should be aware of that particular thing also, right?
Yes, sir. Yes, sir.
Right. Go to the next slide. So the swelling is extending in both the side of the midline and including the swelling in the midline also, right?
Yes, sir.
Okay, so
why you said it is
why the swelling moves up with deglutition? That can be asked. Then you can be asked what are the other swellings which moves up with deglutition, right?
Yes, sir.
Specifically, remember whenever there is butterfly shape swelling, don't ask, don't mention that on protrusion of the tongue swelling is moving up or down.
Yes, sir.
There is butterfly swelling in lower part of the neck. That means in both the side and midline. So no need to mention that the swelling is moving up on protrusion of the tongue or not.
Yes, sir.
Right. So just
Yes, sir.
keep these things points in mind. Right.
Yes, sir.
Purvesh,
Yes, sir.
you said swelling moves with deglutition, up with deglutition.
Yes,
Why
sir.
the thyroid swelling moves with deglutition?
Sir, the thyroid swelling is posteromedially, the pretracheal fascia condenses into the Barry's ligament, which is attached to the cricoid cartilage. And so this whole complex, it is attached to the inferior constrictor muscle, which is the muscle of swallowing. So with the movement, the swallowing movement, the inferior constrictor will move and the whole complex will move. That's why there will be movement with deglutition, sir.
When this movement will be restricted in thyroid swelling?
What happens?
Sir,
When
in
you
case,
find the thyroid swelling without movement with deglutition.
sir, in case of anaplastic carcinoma,
Very good.
in case of Riddle's thyroiditis,
Yes. Yes.
or it can be due to retrosternal extension, retrosternal goiter, sir.
Okay. Right.
And
Sorry, sir, I didn't get that.
and in a rare case of colloid goiter, which are a large colloid goiter. Did you hear it?
Yes, huge goiter, very huge goiter may not give that.
So it is reaching up to even chin. You will not be able to appreciate movement with deglutition.
Yes, sir.
So that should be kept in mind, right?
Okay. Yes, sir.
You have not mentioned about the
Okay.
visible veins.
So why there?
Sir, I mentioned overlying skin is normal, so so that was essentially to include that. Am I audible, sir? Am I audible, sir? Hello? Am I audible?
Hello, Purvesh.
Yes, sir.
Achha, so question is, when will you see the dilated vein in the lower part of the neck or the chest wall in a patient with thyroid swelling?
Sir, in case of a retrosternal extension of the goiter, there will be dilated vessels seen over the anterior chest wall, sir.
Right.
So there will be increased thoracic pressure, which will lead to the congestion, and increased pressure will lead to the dilated vessels, sir.
Okay, go to the next slide.
You said that well-defined margins. Are you sure about the lateral margins?
Sir, I could palpate the margin, the gland reaching up to the almost up to the medial border of the sternocleidomastoid, sir.
But it usually goes behind the sternocleidomastoid whenever the thyroid is enlarged.
Okay, sir.
So lateral border you cannot always say you can palpate or you can make out.
Okay, sir.
Lower border was.
How will you demonstrate the elicitation of relation of the swelling to the sternocleidomastoid muscle? You should know that how to elicit the relation of the swelling to the sternocleidomastoid muscle.
Yes, sir. We have to make that side of the
You want to test
sternocleidomastoid.
on one side, and if you want to test on both sides.
Yes, sir. To test on a single side, we need to ask the patient to turn his head on the opposite side. That will make the sternocleidomastoid over that side taut, sir. For example, if you want to.
Against resistance, that is important. Right.
Yes, sir.
And both?
And for both the sternocleidomastoid, sir, we need to ask the patient to we need to place the hand over the chin and ask the patient to flex his neck against resistance, sir.
Okay. So what are your findings?
Sir, in this case, the swelling was it was reaching only till the medial border of the sternocleidomastoid.
I don't agree with that. Purvesh, even a normal thyroid goes behind sternocleidomastoid. Forget about this swelling.
Okay, sir.
If you are so sure, you should be able to demonstrate. Because in web platform, it will be, you can get away with it, but I don't think anybody will agree with you. It's
Okay, sir.
impossible. What do you mean is that swelling is outside sternocleidomastoid. Remember, both normal lobe are also covered by strap muscle as well as part of sternocleidomastoid.
Okay, sir.
You understand?
I will like to add one step given in the anatomy chapter of mastery, that when you explore the thyroid, you have to incise the investing layer of deep fascia on the anterior border of sternocleidomastoid, so
Yes,
that
sir.
it will fall, and then also you will have to retract little bit to dissect the middle thyroid vein. So
Okay,
all
sir.
thyroid, even a normal lobe, is definitely covered by sternocleidomastoid, as Pankaj Bhai sir has said and Dr. Kirit Bhai sir has said, that many of the times you may not be able to palpate as it is going in the behind the sternocleidomastoid, unless there is severe muscular involvement and very thin lean patient and hyperthyroid, which in that case you might get it.
Okay, sir.
That
So
is
if
also the thin rim of muscles.
If you are insisting up to medial border, nobody will agree with you. I have
Okay,
doubts. You
okay,
understand?
sir.
It
Yes,
is
sir.
always behind it.
Okay,
That's
sir.
why most of the time lateral borders are always ill-defined in
Yes.
bilobe thyroid swelling.
Okay, sir.
Understand? These are the points you should keep in mind.
Yes,
Right?
sir. Yes, sir.
એક બી મેમ તો છે જ નહીં આખા 35 માં. હા? બધાને મેમ જ કહે છે.
શું કહો છો સાહેબ?
એ એક પણ મેમ તો છે જ નહીં, મેડમ તો છે જ નહીં, પણ યસ મેડમ જ કરે છે એટલે.
અચ્છા.
Right? He has some confusion. Anyway, doesn't matter. It's all right. Okay. So keep this thing in mind when you are discussing it. Investing layer is a very important structure when we are discussing thyroid. Similarly, relation to sternocleidomastoid is also important.
Okay,
Right?
Yes,
there also my connection went away. Also keep in mind the strap muscles also get relaxed when you flex the neck.
Yes, sir.
Not only the investing layer. So which are the strap muscles?
So there are 4 pairs of strap muscles.
Again, don't do this. Go and decide 1, 2, 3.
Okay, sir.
The fourth
sir.
is not important here, but anyway.
Okay, sir.
So
if you forget the single name, then it's okay. Unless you say 4, then you have to say 4.
Yes,
4.
sir. Okay, sir. Sir, one is the sternohyoid, the sternothyroid, the thyrohyoid, and the omohyoid muscles.
right. Which is the most important strap muscle in a thyroid surgery?
Sir, sternothyroid.
Why?
Sir, to reach up to to reach up to the gland will the sternothyroid muscles will be will need to incise in the midline the sternothyroid
So we
muscles.
also incise sternothyroid beta. There is no doubt about it. Huh?
I'm not sure, sir. I don't know the answer, sir.
Hold on. What was the question? I missed the question.
Sir, why is so which is the most important step muscle, and why sternothyroid is the most important step muscle? Sir?
Do you expect any structure between the thyroid muscles and a gland?
So can you repeat the question, sir?
Do you expect any structure to lie between the sternothyroid and a gland?
Sir, the middle thyroid vein, sir.
So it will definitely be onto that will be the exit. There is no other structure lying between these two, right?
Yes, sir.
So when you retract these muscles, you will get along with your finger over the whole surface of the thyroid, starting from the superior to the inferior pole.
Yes, sir.
You can bluntly dissect the surface between anterior surface of thyroid lobe and posterior surface of these muscles. The vein lies quite lateral.
Okay, sir.
Did he discuss what importance of sternothyroid?
You couldn't answer it.
The point is that, remember, the point is that sternothyroid is a muscle which covers the upper pole of thyroid.
Okay, sir.
So the previously we used to retract them, but over the time you realize you may retract the sternothyroid easily, or sternohyoid, but sternothyroid is snugly attached near the upper pole. And as we understand that if you want to save the parathyroid and external laryngeal nerve, if you detach the sternothyroid from the thyroid cartilage itself, the exposure of upper lobe is very easy. So most of the oncosurgeon and thyroid surgeon, including me, we always cut only sternothyroid. We do not touch the sternohyoid. Sternohyoid is separated and the sternothyroid is always cut near upper border for a better, because the muscle is of not significance. But if you like that, identification of upper parathyroid as well as external laryngeal lump becomes very difficult. So that is significant at relation of upper pole of thyroid with the sternothyroid. They are very closely attached, and unless you cut it, it becomes little difficult.
Yes, sir.
Okay, one more point somebody was asked. What is the relation of vein? Where is the venous plexus in thyroid?
Sir, it just underlies the true capsule of the thyroid gland, sir.
So what is true capsule?
The true capsule is formed by the condensation of the connective tissue of the thyroid gland.
And false capsule?
So that is formed by the pretracheal fascia, sir.
Okay, so where do we do dissection?
The dissection will lie between the pretracheal fascia and the true capsule, sir.
Very good. And that is the reason if you remain in this plane, what will happen?
Sir, there won't be a chance of bleeding or injury to the vascular plexus, sir.
Vascular, rather the importance is that you will be able to tackle pedicle individually.
Yes, sir.
Particularly middle thyroid vein. If you enter the deeper plane, you will see 3-4 middle thyroid vein.
Yes,
but
sir.
if you remain outside the true capsule and inside the false capsule, there will be only single vein.
Okay, sir.
Right? Where is
Yes,
the middle thyroid vein? What is the position of middle thyroid vein?
Sir, it will be coming on the lateral side of the gland. The medial course directly from
So remember, middle thyroid vein is not middle. What do you mean? Usually it is near the inferior pole, where it is goes laterally. Sometimes it is mistaken as an inferior thyroid vein. So it is not middle. So many times people say, oh, I did not find middle thyroid vein. But actually, most of the time it is lower down, particularly when the thyroid enlarges, it goes little lower. So actually it is not a middle thyroid. This is just not clear in that. Anyway,
okay.
remember, okay.
How can you make sure that this was middle thyroid vein and not inferior thyroid vein?
Very good. Good question.
Sir, middle thyroid will be draining into the IJV, sir.
And an inferior thyroid?
Sir, it will be in the innominate vein, sir. The
Which
brachiocephalic.
Which innominate vein?
The brachiocephalic vein, sir.
No, but which? Right, left? Understand, these are very, again, a trivia somebody may ask you. Both inferior thyroid vein drain into left innominate vein. Both right and left inferior thyroid vein drain into, because the left is a longer course and the veins form on the right side as a superior vena cava. So both inferior thyroid vein drain into left innominate vein.
Okay, what is Goitre's vein?
The coaches, sometimes there is a fourth vein which is draining the thyroid gland. It is located between the middle thyroid and the inferior thyroid vein. It drains
Okay, where does it drain?
It drains into the interjugular vein, sir.
Okay, fine, very good. Right.
So that is why the most of the time we consider as a Cocker's vein actually sometimes.
Right.
Either to consider as the middle thyroid, and many a time Cocker's vein replaces the middle thyroid vein.
Right.
Okay. So understand the true capsule, false capsule, these are the things which can be asked.
Yes, sir.
Okay.
And middle thyroid is a shorter vein and which enters into at the 90-degree angle most of the times.
Yes, sir.
Where the Cocker's goes oblique course.
Okay, sir.
Swelling moves, lower border is palpable.
How
Sometimes
will you tackle middle thyroid vein injury? Suppose inadvertently one is damaged in middle thyroid vein and you are called for repair. How will you prepare your mind or instrument to tackle this bleeding? Hello, am I audible?
Yes, sir. Sir, I'm not sure, sir.
So it is very short vein and practically you have to repair the internal jugular vein. Right? With
Yes, sir.
the way you tackle any major venous structure, you have to tackle it. You have to apply the vascular clamp so that the lumen is covered, and you have to take few fine polypropylene sutures. The way you suture any major vein like IJV or superior vena cava or inferior vena cava. This is how you have to tackle. You don't.
I would add one more thing, Hitesh bhai.
Yes, sir.
If you are a good surgeon, first thing you do is pack it and wait.
Yes, sir. Absolutely.
Even especially in a middle thyroid, when it gets avulsed from internal jugulary, initially it looks a disaster. But
Yes.
if you pack for 5 minutes, you can do whatever you want. So first thing, pack it and then use the vascular.
Then make sure that the position of head and neck is proper. You can raise it and then keep the suture material and clamps available, and then try to dissect the proximal distal IJV if possible. And then you try to search the rent in the interjugular vein and repair it with 1 or 2 sutures. That's enough.
Okay, sir.
I damaged it in my second year of the surgery and repaired also. GCRI.
I am also doing it even now many a time. It happens, but the point is that patients and packing. That's what I believe. Anyway, okay. People want that getting below to you. What Dilip, what do you say? Should he say this lower border is palpable, or the getting below the swelling is possible?
Actually,
both are being used.
One should at least mention that lower border is defined.
He has written that. It is right. He has written that.
Right.
The difference is that getting below the swelling is why word is used. Why we use many a time getting below the swelling. This is fine. I don't say it is wrong or anything, but sometimes some examiner will particularly will ask What do you mean by getting below the swelling? Do you hear me?
Yes, sir.
Purvesh, yes?
Yes, sir. Yes, sir. Am I audible, sir?
I always
Yes,
say,
yes, yes.
just when you have mentioned swelling moves up with deglutition, there is no need to mention moves up. It always moves up. Swelling moves with deglutition. That's it.
Okay.
But at
Okay,
least
sir.
don't say that moving down with after
Okay, sir.
downward should not come. That is very
Okay, sir.
essential.
So, students have habit of adding unnecessary adjectives, which sometimes create problems.
Okay, sir.
On
So-
palpation, sorry, sir.
Yes,
Please.
Kirit bhai.
What my question was not answered. What do you mean by getting below the swelling possible? Why it is important?
Sir, it is to rule out if there is any substernal extension of the gland, sir.
What is substernal?
Retrosternal, sir.
Huh? That's what the Hitesh bhai was saying. Stick to the normal. You may not be wrong, but the people will ask you what is the difference between retrosternal and substernal.
Okay,
Maybe
sir.
same thing. So stick to the normal words. Okay,
Yes, sir.
Kirit bhai, you were asking something.
Sir. You haven't mentioned the shape of the gland on palpation. Actually, there are multiple nodules, true, but it can be on the isthmus also, and then you have to mention the shape also.
Okay, sir. Sir, it was bilobe, sir.
That already Modi sir told that it's a bilobe swelling. So you should mention the shape in multinodular goiter is very important. And if you can able to palpate the isthmus, then also you should mention.
Okay, sir.
Another important thing is in multinodular goiter, whether you palpate any dominant nodule or not. That is also very important. You should must know the definition of simple multinodular goiter, solitary thyroid nodule, and dominant nodule. So in multinodular goiter, if one nodule is very prominent, then you can mention that there is a dominant nodule on that particular swelling. If it is,
Yes, sir.
right?
What is the significance of dominant nodule?
Sir, dominant nodule would usually be an autonomous nodule, sir.
That means you mean to say it must be a toxic case. You mean to say in that way? Dominant meat is just a prominent nodule. Clinically, it is just a prominent nodule, not necessarily it is autonomous toxic, not in that way.
You have to differentiate whether it's a solitary nodule or a dominant nodule of a multinodular goiter. Not in this case. In this case, it is very clear. But whenever there is a irregular shape, so you have to clearly make out whether there is a dominant nodule or there are multiple nodules.
Okay, sir.
Next. I think sometimes they may ask you bilateral carotid pulsation felt normally. What is the site where you look for a carotid pulsation?
Sir, it will be at the level of C6 vertebra against the tubercle. That is the Chasnick's tubercle. We palpate the common carotid artery, sir.
But how will
You
you know
mentioned-
from front side? How will you know from front side?
Sir, it will be at the level of the cricoid cartilage, sir.
No.
No. This is a basic thing.
Hmm.
Expect you to make this mistake. Huh?
Medial to the sternocleidomastoid, sir.
That's right. But what is the level? Transverse level?
Level is important.
At the level of thyroid cartilage.
Upper
Where?
border.
Thyroid cartilage is a big cartilage. Below, middle, upper border, where?
It's a upper border of thyroid cartilage. Line drawn at the upper border of thyroid cartilage, or some use word most prominent upper part of thyroid cartilage. Some also use the Adam's apple word. Depends. But uppermost portion of thyroid cartilage, transverse line drawn, which crosses the anterior border of sternocleidomastoid That is the site you will find C6 vertebra, but C6 transverse process tubercle.
Okay,
Your name you have written, but word transverse process should come. It's a
Okay, sir.
tubercle over C6 vertebra transverse process.
Okay,
You
sir.
palpate against that tubercle, right?
Yes, sir.
Why it
Yes,
is
sir.
important to know the normal site?
Sir, because in case of encasement by a carcinoma, there may be absent carotid pulsation, or in case of a large goiter, it may be pushed posteriorly.
Displaced. Better word is displaced. Right?
Okay, sir.
So why this happens? Why in large benign goiter carotid pulsations are pushed? What is the reason? Anatomical reason?
Sir, the carotids lie in the carotid sheath, which is located laterally to the gland.
I did not understand what you want to say.
Sir, in normal anatomically, the carotid will lie in the carotid sheath, which will be lying anterolateral to the gland, sir.
The point you should understand, the thyroid and carotid both are in its own fascia, that is a pretracheal fascia. In irrespective of size of the thyroid, if it is benign, it will be contained within the pretracheal fascia. The absence pulsation occur only in a case when there is a breach of pretracheal fascia and invasion, right?
Okay, sir. Yes, sir.
What other thing will you see? You will see presence of pulsation, absence of pulsation, displacement of pulsation. Any other thing you will palpate here?
Sir, we'll palpate for thrill.
Thrill, yes, yes. So you
At
make
the superior pole, sir.
turbulence of the flow, excessive flow in the superior thyroid artery pole, right?
Yes, sir.
Next slide. Oh, why do you do percussion?
Sir, again, to rule out retrosternal extension, sir.
So where you do percussion for retrosternal extension?
Sir, on the above the sternal notch, sir. And on the manubrium, sir.
And on auscultation, you say no audible brew on auscultation, right?
Yes, sir.
Okay, so what is your diagnosis? Or you would like to do some systemic examination also? Next slide.
General systemic examinations.
That's all normal, correct?
Yes.
Okay, so what is your clinical diagnosis?
Sir, my provisional diagnosis is a case of non-toxic multinodular goiter, sir, due to benign etiology.
What is the likely etiology in your case, considering all your history taking and everything?
Sir, it may be due to a physiological cause, sir. The patient had swelling since she noticed the swelling since 5 years, and her first pregnancy was about sir, around that time, sir.
Would you like to give any differential diagnosis?
Sir, it could be due to Hashimoto's thyroiditis, sir, or it can be a colloid goiter, sir.
Why you want to put a Hashimoto's thyroid?
Hashimoto's, yeah. Why do you want to put Hashimoto's?
Sir, Hashimoto's because, sir, it will also be the swelling. The patient will also present with a swelling that would be nodular or granular, and
But what about systemic features?
sir, in 20% cases, Hashimoto's does have hypothyroidism, but the patient.
No, but hypothyroid, no. Hypothyroidism is a late stage. Before that, so most of the patients they start with thyrotoxic, Hashitoxic, whatever they say, a brief phase of hyperthyroidism, which is almost always there. So if you have those things, it is fair enough. Otherwise, I would say that you stick to your diagnosis of physiological goiter converting into a multinodular or this colloid.
Okay, sir.
Okay, so how will you do?
Yeah, how will you proceed with your investigation part and then the treatment part?
Sir, first I would like to go for thyroid function test. This is the TSH, free T3 and free T4, followed by.
So why do you want free T3 and free T4? Why do you want to do it? You say it's a euthyroid patient, so why not a simple TSH should do?
Sir, we can
Or
go
a routine. Yes.
So simple TSH would do, but it is a recommended. It is a good practice to even check free T3 and free T4.
Okay.
So after that, I would.
So then you their thyroid profile will come to be normal, correct? Almost as per what you say.
Yes, sir.
It should be normal. Okay. So then what you will do?
Sir, I would like to go for routine blood investigations, like a complete blood count.
So that is for any particular thing, or is just a fitness of the patient?
Sir, it is because if you are going to start the patient on any drugs, sir, such as
Why, and what drugs?
Sir, in case the patient has hyperthyroidism.
This is the patient. You yourself say there is no hyperthyroidism, no hypothyroidism. So it's a euthyroid. Already in your diagnosis, you have written euthyroid multinodular goiter. And why do you want to go for? Why do you want to start such medication? Why?
In this patient, sir, for
See, ultimate, Purvesh, one thing is very sure. Ultimately, we talk only about this patient. The questions may be n number of things, but when it comes to management part, it is always for this patient.
Okay, sir.
And for each investigation, you tell the relevance of the investigation to your case, right?
Yes. Sir. So when you find that thyroid profile is normal and it is corroborative with your clinical finding, then what will you do? What will be your next stage?
So we'll go for ultrasonography. Ultrasonography,
yes. And what
of the
will you
neck.
find?
Sir, to find first the nature of the nodules, whether they are solid, cystic, or mixed. Then to look for any lymphadenopathy, and to look for the number of nodules, and to look for any features of malignancy. And if any of the nodules
give the systematic answer. Purvesh, give the systematic answer. What is thyroid's different types? What is thyroid resolution sonography is concerned?
Sir, there
like the breast bireds, it is a thyroid. So
yes, sir.
Component of it and.
So there are 5 grades of thyroids. Thyroids 1, 2, 3, 4, and 5. Thyroids
so it is 6. It is 6, not 5. Okay. Now tell me what is first, what is second, what is third?
So thyroids 1 is benign, where it is purely cystic lesion.
No, it is normal. 1 is normal. There is no abnormality, right? Okay.
So, thyroids 2 will be, sir, benign, where it will be purely cystic lesion. Thyroids 3 will be very low suspicion of very low suspicious nodules, sir, where there will be spongiform nodules seen.
So 3 is also considered as a benign. Okay. Now important is, as far as the suspicion is concerned, is between 4 and 5. With both suspicious. Now what are the different changes that is observed in sonography? Why it becomes suspicious?
Sir, there will be change in echo texture. Malignant suspicious nodule will have it will be hypoechoic.
Yes, hypoechoicity is one.
Sir, another is the shape, sir. Shape taller than wide is again suggestive.
Oh yes, that's good. Taller and wide, that comes last. A, B, C, D. So last is taller and wide. First is that what you say hypoechoic, right?
Yes, sir. Next are the
that is B. What is B?
Sir, margins.
Margin. So it is irregular margin, right?
Yes, sir.
Totally encapsulated type of lesion, but there are irregular margins seen in the nodules, right?
Yes, sir. Next will be, sir, presence of any calcification, the microcalcification, sir.
Microcalcification comes fourth. The third is the vascularity of that peripheral rim of vascularity and that.
Yes, sir.
These are the A, B, C, D, four group, and depending upon that particular presence of appearance in that fourth and fifth suspicious types of thyroids, it is considered as a more towards the malignant side. If it is more than one component present among all these four components which are mentioned, right? And what is 6?
Yes, sir. Okay, sir.
So this
is a malignant.
Six.
The shape.
It's a biopsy proven case basically.
Shape.
6 is a biopsy proven case, that is it, as far as malignancy is concerned, right? So
Yes,
after sonography, what will you do? These are the information you want to get from sonography. Now, what other investigation you would like to go for?
Sir, in case if on sonography there is a suspicious nodule, I would like to go for a FNAC, sir.
Okay, so fine needle aspiration cytology. So there are multiple clinically palpable nodules. Whether it is possible to judge clinically that from where will you do the biopsy?
No, sir. I'd like to go for ultrasound guided cytology.
Now, whenever you are planning ultrasound guided FNAC, what is considered as a satisfactory FNAC?
Sir, for a satisfactory FNAC, there should be at least 6 follicles present, and each follicle should have.
It is not 6 follicles. It is a 6 aspiration to be made.
Yes, sir.
It is 6 aspiration to be made. Now, what are the quality of this aspiration which considered as a satisfactory?
Sir, 6 aspirations, it should be having at least 6 follicles in them, and each follicle containing at least 15 to 20 cells, sir.
Yes, 20 cells. It is said that FNAC is to be considered satisfactory when you at least see minimal 20 cells in each aspiration, right?
Yes,
so
sir.
You can have a proper judgment of the diagnosis, and definitive you can grade according to the FNAC, the report also.
Yes, sir. It is
the different grading of the report of FNAC.
So the grading done is known as the Bethesda grading system. The first one is indeterminate.
Yes.
The second one it will be benign. Then third it will be AUS, that is ATP of unknown significance. Then suspicious for follicular neoplasia. Then suspicious for malignancy, and proven malignancy.
Okay, so these are the Bethesda grading about the 6 types of FNAC report which you may expect for that, right? What is FNNAC? FNNAC, what is that? FNAC is 1, but what is FNNAC?
I don't know, sir.
That is fine needle non-aspiration cytology. N is for needle and non, in which certain wide bore needle is used. It is directly the pathological area under ultrasonic iridance is punctured, and no more aspiration is done. Just by touching the syringe, the whole needle is taken out and the specimen is examined. What is the importance of doing this FNNAC? So recently it is said that by FNNAC, there is dictum that follicular cells cannot be diagnosed as a malignant or it is a benign, right?
Yes, sir. Yes, sir. It is
check for the vascular invasion and that.
Capsular invasion. Yes.
Recently it is said that if you go for FNNAC, the character of the cells you get, you may be able to define whether there is a more favorable monoploidy or aneuploidy, or monoclonal or multiclonal component of the follicular cells, which may help in reaching towards the diagnosis that this particular cells may be a cancerous.
Okay, sir.
So that is specifical importance of FNNAC.
Yes, sir.
Better if you can remember this particular component.
Okay.
FNAC, what is FNNAC, and important thing is how to report. How do you get the report of FNAC? And ultrasonography, what is thyroid? You should at least remember these things in detail. It will be help to you for getting the credit marks and all that.
Yes, sir.
Now, any investigations, whatever we have suggested is done in your patient?
Sir, I got the thyroid function test done.
Right.
It was suggestive of, sir, the patient was hypothyroid. The TSH was elevated to 11 microunits.
And what is the sonography and FNAC report in your patient?
Sir, the sonography was suggestive of bilateral lobes with the isthmus bulky, with altered echotexture and increased vascularity, with multiple nodules size of size 16 by 22 by 26 mm.
In hypoechoic nodule, any at multiple places solid component was seen?
Yes, sir. On the right lobe, sir. On the right lobe, there was a nodule which had mixed solid cystic component, and the rest of the nodules were isoechoic, sir. It was suggestive of thyroid grade 2, sir.
Grade 2, right? So it is over the benign side, basically, right?
Yes, sir.
What is the? Have you undergone FNAC also?
Yeah, yes, sir. The FNAC was suggestive. It was showing follicular cells arranged in macro and microfollicular pattern, and it was suggestive of colloid goiter, sir.
Okay. So with this diagnosis, multinodular non-toxic benign goiter, what will be your further management? Would you like for radioisotope scan?
No, sir. The radioisotope scan is not required in this case.
Not required. Right.
My question. So, my question would be, where do you need a scan?
Sir, in case of a toxic nodule, we need to go for a scan, sir.
Okay. Do you know? Okay. Go ahead with Apurva. Right.
So, no, only one thing. In case of a single toxic nodule or something else. See, the thing is, if the patient has a solitary thyroid nodule,
yes, sir,
and if it is hyperthyroid, see, again, the thing is, most of the time we go for a hemithyroidectomy. We don't go for excision of the nodules.
Yes, sir.
Right. So, there are very limited indications for thyroid scan, especially as I have aberrant thyroids.
Yes, sir.
It is when you are suspecting metastasis or something, a thyroid scan may be helpful, or there is only a single swelling which is not in the thyroid area, and you feel that probably that is the only thyroid of the patient.
Okay, sir.
As an ectopic place, right?
Yes, sir.
Otherwise, thyroid scan is a very limited role.
Okay, sir.
Okay. So what are the isotopes are used? Do you know what are the isotopes used for thyroid scan?
Yes, sir. For diagnostic purpose, we use the iodine 123. While for therapeutic, that is ablation, we use the iodine 131, sir.
Okay, if you want to diagnose a medullary carcinoma of the thyroid, which radioactive iodine, which radioactive isotope?
So we'll go for technetium 99 technetium per
No, it is not technetium. It is imedium 111.
Okay, sir.
Imedium 111 scan is utilized for diagnosis of medullary carcinoma of the thyroid. If you suspect Hurthal cell tumor, then which radioisotope scan is used? Hurthal cell tumor.
Sir, technetium.
No, it is not technetium. It is system scan. So keep this particular, it may be of importance sometime when you say something, and if you are trapped in that, if you know these answers, then it will be of help, right?
Yes, sir. Yes, sir.
Okay, now what will you do for this patient?
Yes, what will you do?
Sir, for this patient,
so you have type 2 in sonography. It is benign condition in that. You say it is a colloid and multinodular goiter. So what treatment will you offer in this patient?
Sir, the treatment that can be offered would be surgery. So first of all,
okay, why you want to go for surgery in this patient? Why not conservative?
What is the age of the patient?
Why you want to operate this patient? Patient is insisting, or it is your choice?
So the patient came.
Of asking the question is that if you don't operate, what will happen?
So there will be there can be complications in the future there can be secondary toxicity, or there can be
Secondary hyperthyroidism, right?
yes sir. Yes sir.
Specific word. Okay. Second.
There can be malignant conversion, malignancy.
Okay, fine. Then, which carcinoma is more likely to occur in multinodular non-toxic goiter? Which one?
Sir, follicular.
Follicular. Okay, fine. Then,
Sir, it may cause. Sir, if it continues to grow, it may cause compressive symptoms.
yes.
It has increased this particular size in 5 years. There is no sudden increase in the size. And what is the age of the patient?
Sir, it is 27 years.
So how many child she has?
She has one living child, sir.
So she might be opting for the second child also. She might need second child.
Yes, sir.
If you do total thyroidectomy or thyroid surgery, is it going to help her?
No, sir.
So what are the treatment options available for this patient except surgery at the age of 27 years?
Suppressive therapy, thyroid, antithyroid drugs, sir.
Antithyroid drug? You mean?
Hypothyroidism.
How can you use antithyroid drug in
thyroid
this
drugs, sir, sorry.
Don't make such mistakes.
Thyroxine.
L-thyroxine, sir.
Yes.
Yeah, so thyroxine you can give as a replacement therapy.
How it will help?
Sir, it will lead to suppression of the TSH, which will lead to, which will cause, which will stop the further.
So you want to only suppress the TSH? What is your aim for giving L-thyroxine? Just to replace the hormone? It is something else.
Replace the hormone and
what is the reason for occurrence of
TSH is elevated?
We already discussed.
Sir, to make the patient euthyroid.
Patient is euthyroid only.
Why you want to give L-thyroxine? Can it cause hyperthyroidism if the patient is euthyroid and you keep on giving L-thyroxine?
Yes, sir.
No, it is not like that. The reason is something else.
Biofeedback.
You want to give L-thyroxine.
Sir, can you repeat the question, sir?
Okay, what is the purpose of giving L-thyroxine in this patient? Only one sentence, your answer is required.
Sir, as a
patient is having no problems, right? There is no hyperthyroidism, no hypothyroidism. You have done investigations, it is benign, right?
Yes, sir.
So what the problem lies? The size should not increase.
You already told that the fluctuating level of the TSH is causing nodules.
Yes, sir.
What do you do by giving L-thyroxine?
Sir, it will stabilize the.
Yes, it is the
TSH.
persistently stabilized level of TSH. That should be the answer rather than reducing it or that. That is not a correct answer. But persistent stabilizing the level of TSH, there won't be any fluctuation, so there won't be any more development of the nodule.
Okay, sir.
How will you monitor?
Sir, I'd like to, first of all, clinically, on follow-up, I'd like to clinically examine the patient for pulse. And secondly, I'd like to go for TSH. TSH evaluation, sir. Am I audible, sir?
Only pulse clinically or anything else? Sir already had given you the hint, Choksy sir.
कही दो साहब. किरेट भाई कही दो.
It should not convert into hyperthyroidism. If you consistently keep on giving thyroxine without monitoring the patient, so clinically pulse, the weight of the patient, as well as the size of the thyroid gland. Everything you should monitor.
Okay, sir.
Actually, you have not mentioned the circumference at the maximum swelling size of the neck, right?
Yes, sir.
On examination.
Sir, I mentioned, sir, 8 by 5 centimeters for the.
No, circumference of the neck at the site of maximum prominence of the.
No, sir, I have not taken that, sir.
So that should be mentioned whenever you do final presentation in your 7th September, right? You include.
Okay, sir.
Right.
Yes, sir.
Okay, so suppose you want to go for surgery, what surgery will you recommend?
Sir, I'll like to go for near total or total thyroidectomy, sir.
Why you want to go for total thyroidectomy?
So to prevent chance of any recurrence, sir.
So what do you understand by hemithyroidectomy, partial thyroidectomy, subtotal thyroidectomy, total thyroidectomy, and radical thyroidectomy? You just explain all these terms.
Sir, hemithyroidectomy would be one entire lobe along with the isthmus. Second would be subtotal thyroidectomy, where we on one side the entire lobe along with the isthmus, and on the other side we're leaving some tissue, about 4 grams of tissue intact, sir.
No, that is near total thyroidectomy. That is not subtotal.
Subtotal is we don't do nowadays. It is the tissue is kept on both the sides.
Both the sides. About 4 grams of tissue is left on both the sides, sir. And near total, or also known as Hartley-Dunhill procedure, sir, where it will be subtotal on one side and complete lobectomy on the other side, sir. And total thyroidectomy would be removing both the lobes along with the isthmus and the pyramidal lobe, sir.
Choksab, anything else? And surgery followed by replacement therapy of the thyroid.
Yes, sir.
When will you start replacement therapy after total thyroidectomy?
Sir, it will be immediately after the surgery, sir, next day.
Usually you start after 7 days because the half-life is more, right?
Yes, sir.
Okay.
अंदर साहब Choksab has lost the connection. बीजू कोई पूछवा जाऊँ साहब किरीट भाई?
No, I think
we have completed. I think.
Yes.
I think we should finish.
Okay. Yeah. Okay, Purvesh, well done. Thank you, Andhar sahab, Choksab.
Thank you, sir.
Kirit bhai, we'll take a leave there. Okay.
Kirit bhai, thank you. Special thank you.
Thank you,
sir.
Thank you, sir. Apurva sir, thank you.
Okay.
Modi sir,
Okay.
thank you.
Bye.
Andhara sir, thank you.
Thank you, Kirit bhai.
Modi sahab, sir, છે પણ અરે. Okay.